Good afternoon, everyone, and thank you so much for giving me the opportunity to speak before you. I would like to thank Dr. Alia Khan, McMaster University, and OSSM, the Union of Medical Care and Relief Organizations, for this great opportunity and great CME. My name is Anas Al-Kassem. I'm a general surgeon, MIS, and bariatric surgeon. I work at Norfolk General Hospital, and I have a special interest in obesity management and bariatric surgery, and that's going to be my talk today. So the main objectives of the talk is to review the obesity pandemic, the indications for the bariatric surgery, a review of the surgeries available in the history and nowadays, and the benefits of bariatric surgeries. Unfortunately, I don't have any disclosure. I do work for the medical care and relief organizations as a volunteer and board member, so I go on medical missions for trauma and to help in the general surgery missions, but I don't get any financial benefits. Let's talk about obesity as a pandemic. Today, as we're talking about COVID-19, there's a pandemic that we don't talk a lot about. There's 2 billion adults and 350 million children affected worldwide with overweight or obesity. More than 15 million Americans have morbid obesity, and more than 1 million Canadian, they have obesity, morbid obesity. And this is just to compare a snapshot between 2000 and 2016. And you can see that the North America, South America, and Middle East have been heavily affected with the pandemic. There's more than 60% of prevalence of overweight or obesity. But the stunning thing is that in Africa, if you look here in the middle, in 2000, most of it used to be yellow. Now it's orange, which means that more than 20% in some areas of Africa, more than 40% of the population is obese. So we're not alone here. So why bother treating obesity? Well, this was a good study published recently in The Lancet in 2018. 3.6 million patients' records were retrieved. That's about 9% of the UK population, quite significant portion. And they studied the link between obesity and death. And they followed the patients for over 11 years on average. So that's pretty significant. And here's the results. The bracket that we all like and comfortable to be in terms of the BMI is about 20 to 25. And if you look at that as a benchmark, when the BMI goes up to 30, you know, the hazard ratio of mortality goes up a little bit. But when it goes to 40, the BMI goes to 40, particularly in men, which is yellow here, the hazard ratio is about 2. So the hazard ratio is double the rate of 20 to 25 BMI. And when the BMI goes to 50, the risk of mortality goes as high as a 3-fold. This is a pretty significant study for 9% of the UK population. So we know that obesity leads to increased mortality. And this is to study the effect of obesity on life expectancy at the age of 40. And if you look again, the bracket of normal weight between 18.5, 24.9, the life expectancy at age 40 is 82.2. For women, it's 84.3. But when you go down, overweight, probably not much of effect. But you see here, the obese population, BMI over 30, like class 1 obesity, and class 2 over 35. And over 40, you see that the life expectancy dropped to 73 for men and about 76 years for women. That's significant reduction in the life expectancy, about 9 years for men and about 7.5 years for women. And that's another study by UOSSM team, again published in The Lancet in 2004, studying the interaction of obesity with multiple risk factors driving the risk of MI. Very interesting study. Smoking by itself increased the risk by 2.87. Diabetes has odds ratio of 2.3 for MI, and hypertension by itself about double. If you look at obesity, which is by itself a risk factor for smoking and, sorry, for diabetes and hypertension, I should say, um, it's 1.6 only. But when you multiply all above, including smoking, then the risk is way higher than diabetes, hypertension, and smoking alone. It's a 21 odds ratio of MI, very significant. I just want to remind everyone, probably you know about that, the subcutaneous fat. Most of women, they have more subcutaneous fat beneath the skin, as opposed to men. For some reason, they like to have more visceral fat inside their body. The subcutaneous fat is not as risky, not as risky. There's no ectopic fat. But when you have lipid overflow with altered fatty acid metabolism, altered release of adipokines, this is when the risk becomes high. When you see a clinically fatty liver, epicardium fat, increased muscle fat, and then metabolic syndrome will happen. So always focus on the visceral fat. Not all the fat is bad fat, as we say. And same thing applies to the food. There is good fat and bad fat. Olive oil is fat, but you can eat as much as you want. But if you dip a Mars bar in lard and you want to eat it, this is probably the most atherogenic food you can eat. So you have to differentiate between the good and bad fat. So we know that obesity can lead to increased MI, and we have evidence that it will decrease the life expectancy. So how should we manage that? With life changes, lifestyle changes, with dietary changes, pharmacologic interventions, or with surgery? Well, let's see what the literature supports. This is a systematic review showing that sustained weight loss with only behavior interventions, meaning diet, lifestyle, exercises, will be beneficial, but just gonna give you 3 to 5% reduction in your initial body weight. That's most of the study, again and again, shows pretty much the same results. In terms of medications, we'll give you a boost, probably to about 12% reduction in the weight, initial weight, but it's not going to give you 20 or 30%. As opposed to surgery, it does give you a significant reduction in the weight, 20 to 30%, and with significant substantial reduction in the mortality and morbidity. This is a very good, strong trial. It's a randomized trial. There's only few randomized trials to compare the effect of bariatric surgery versus extensive medications or pharmacologic interventions for obese population by Schauer and his team. The Stampede trial, which was published in 2017 in the English Journal of Medicine. So it shows that there is 23 kilogram drop on average in the weight at 5 years, as opposed to 5 kilogram with the medical treatment. Again, bariatric surgery is way more superior than medical treatment when it comes to high BMIs. So if we know that it does work and is superior in the high BMIs, when should we consider bariatric surgery? When again, these studies shows and support that BMI over 40, the failure rate will be high with a diet and behavior interventions in addition to medications. So bariatric surgery become more indicated. And a BMI over 35 with comorbidities, including hypertension, diabetes, and sleep apnea. And even in some population, for some reason, particularly in the Asian population, there is more benefit even at BMI of 30 and higher. And this is some statement by the American Heart Association, the American Diabetes Association, and International Diabetes Federation all support bariatric surgery for diabetes type 2 and BMI at 35 or above in some population as well when diabetes is not adequately controlled for BMI over 30. I don't want to go over this detailed slide, but I just want to show a point here that bariatric surgery is not only restrictive, and most of the bariatric surgeries, particularly I'm going to talk about few in a minute, sleeve and gastric bypass and the duodenal switch, it is quite complicated how it works. quite complex in terms of the hormonal effect. When you have hyperglycemia, you have decreased antioxidant activity, increased polyol pathway, lipid peroxidation, and so forth. It does block these pathways significantly. So bariatric surgery has been shown to show significant hormonal effect and not only restrictive effect in terms of the effect on diabetes and coronary heart disease. Okay, but here's a but. We know that in Canada, we have about 2 million people with a class 2 or class 3 obesity. That's 6% of the population. However, there's only 5,000 annual access of that eligible population for surgery. So that means 5,000 per million eligible population. They have access for national covered. I'm speaking of something like OHIP we have in Ontario. And if you look at the provinces like Quebec, they have probably the best national program. About 10 in 1,000 are covered, but or they can have access to the surgery. Versus in Ontario, it's 6 in 1,000. British Columbia, only 2 in 1,000. In some provinces like PE Island, they have no national program to cover bariatric surgery. We know that gastrectomy as surgery, to cut the stomach or transect portion of the stomach does work for diabetes. This was observational study done in 1955, and they found that doing a resection of the stomach for different reason, it does cause remission of diabetes. So we know about this concept from 1955, nothing new. Just to go over the surgeries we have available or over the history. This is Dr. Ed Mason, whom I had the privilege to meet a few years ago. He died, unfortunately, just a month ago, 29th of December 2020, at the age of 100. He was quite active, and he told us that he used to keep running and kept active until he was like in his late 90s, and he used to swim on a daily basis. He's the one who started doing gastric bypass for obesity. This is the principle Dr. Mason started, and this was years ago, and there was lots of modifications over the years. It's a great procedure. It's done laparoscopically nowadays. Has a great hormonal effect, so it's great for diabetes and metabolic syndrome. But it still does have significant complications in comparison to other procedures, but it's great for the morbid obese population, particularly if diabetes have been for more than 5 years. Okay. This is the vertical band gastroplasty. I only trained to treat its complications, never did one when I was in Texas years ago. And so it's restrictive and hormonal, but the problem, the surgeons get away on it because of the significant obstructions and GERD in this portion of the stomach because of the tightness and the band that we put at the bottom here. So it's pretty much out of the market. And this is the gastric band. Many of you see this in their practice. Actually, I've taken more bands than I put band in. And I do that at Norfolk Hospital, and because of complications. And it used to be at some point very popular at 1992 until probably 2000 and 2005, and the gastric sleeve started to take over the market. Gastric sleeve started in 1993 by Marceau, and then Michel Gagné, who was a pioneer Canadian surgeon, he modified the procedure in a beautiful way and got much better effect once he talked about removing the body and the fundus and just leaving the antrum. It is the most common laparoscopic bariatric procedure being done. Unfortunately, it's not covered by OHIP, I think just because of the funding issue. It's proven to be probably as good as the bypass with less complications though, but it's only covered if you have a small bowel disease, and therefore most of the time it's being done privately at the current time, particularly in Ontario. Okay, duodenal switch is combination of sleeving the stomach and doing extensive bypass, and we leave this just for the super severe obese population with BMIs over 50. And sometimes we do the sleeve at first stage, and the second stage will be the duodenal switch. And I'm just going to talk about the gastric balloon for a second because I'm sure you hear about it. It's only good for 6 to 12 months. It's only good if you want to lose 10% of the initial weight, but not it doesn't even match the gastric sleeve and gastric bypass in terms of the effect on the weight on the long term, and particularly diabetes, hypertension, other diseases. So it's temporary. It's good if you want to go on a cruise or get married probably, but it's not good probably if you want to lose 20 or 30% of the weight. So we know that surgery does work, and we know that it comes with a great benefits. But just let's talk at the end of this talk about the benefits of the bariatric surgery and what's in the literature to support that. This is again talking about the Stampede trial. It's a clinical randomized trial showing that 25% of patients with diabetes type 2 achieved an HA1C of less than 6% with significant decreased use of insulin as opposed to the controlled group, which have been treated with medications alone. And the Changa trial at the bottom showed great benefits to reduce hypertension, obstructive sleep apnea, dyslipidemia, and many other diseases at the 3 and to 5 years after the bariatric surgery. So we know that there is significant reduction in HA1C as opposed to medications. And this is just to show the resolution of diabetes and a systematic review by Buchhold, published in 2009. And it's a great effect on the resolution of diabetes. 77% in terms of gastric sleeve. This is gastroplasty or gastric sleeve. 70% at 2 years resolution of diabetes in terms of bypass, and 95% impressive in terms of duodenal switch. Again, it comes with the cost of more malabsorption. So the more you go to the right, more malabsorption, you're going to get a great effect on the metabolic syndrome, but more malabsorption as opposed to the gastric sleeve. And finally, what about the effect on coronary heart disease? When this is a great study published in JAMA in 2018, comparing bariatric surgery patients with matched non-surgical patients, starting with the same BMI. And at 7 years, it's impressive. The hazard ratio for coronary heart disease is 0.64 in the bariatric surgery population at 7 years versus non-surgical patients. Significant reduction in coronary heart disease at 7 years after surgery. What's more stunning is the all-cause mortality at 7 years. Significant reduction by almost 66%. The hazard ratio is 0.34 at 7 years as opposed to the matched non-surgical patients. Significant reduction in all-cause mortality at 7 years after bariatric surgery. And this is just some numbers in terms of the effect of metabolic risk factors. In addition to the BMI, we've talked about HA1C drops significantly in gastric bypass and sleeve. The HDL jumps by 13 points and 16 points in the sleeve, and significant reduction in the TG and CRP. So surgery, it's gaining significant improvements in terms of the safety. The mortality is about 1 in 1,000, which is similar to the mortality of laparoscopic gallbladder surgery that we do laparoscopically as well. There is a little bit more complications than lap chole for sure. It's still very acceptable, about 4%. And the risk of living with morbid obesity, as we have shown, really outweigh the risk of bariatric surgery. Final key points. To summarize, bariatric surgery does cause significant improvement or resolution of many obesity-related conditions, from diabetes, coronary heart disease, sleep apnea, dyslipidemia, cancer, and so forth. There's a significant drop in HA1C, over 60%, depending on the procedure. As we said, the more malabsorptive you go, the better the effect on HA1C, but you have then to deal with potential malnutrition. It does increase the HDL significantly. It reduces the coronary heart disease by 36%, and it does decrease all-cause mortality by 66%. And as we have seen, and at least in men, it does increase the life expectancy by 9 years and over 7 years in women. until there's a pill or vaccine, as we're talking about vaccines nowadays, everyone, bariatric surgery is the most effective approach to weight and adverse obesity outcomes. Thank you very much for your listening, and we're ready to take any questions.